Today, our focus is on lung cancer. I'm pleased to be joined by Dr. Joseph Baisden with 21st Century Oncology. Thanks for being here this morning.
Thanks for having me.
Well, let's start with a general overview on lung cancer. A lot of people think that smoking and lung cancer go hand in hand. That's not always the case. What are some other risk factors?
Well, other risk factors, probably the second largest risk factor is radon exposure. And then the third largest would be occupational exposures, things like asbestos exposure, or other inhalants that folks are exposed to in coal mines or other mechanic type jobs. Secondhand smoke is also in there, but really 90% of lung cancers are probably mostly due to tobacco use and smoking.
And does it seem like lung cancer rates are dropping now that we know about the dangers of smoking?
Well, actually, they haven't been. Since 1975, there's been a little fluctuation, kind of up and then back down to about the same incidence it was in 1975. But there's really a difference between men and women in those rates. Men had a peak in their incidence at about 1985, and it's gone down about 30% since that time for men. Over that same time period, it's really kind of gone up and then leveled off for women. And we think that that is about a 20-year lag time behind the use of tobacco there. So men had a peak in 1965 or so, very high rates of tobacco use. And women were about 20 years behind or 15 years behind in really adopting widespread tobacco use in our country. And we think that those rates follow that.
What are some of the symptoms people should be on the lookout for?
Okay, well, the problem with lung cancer, one of the main problems is early lung cancer is usually asymptomatic. The lungs don't have any pain sensors, so it usually relies on something happening like folks start coughing up blood, or they have worsened breathing, weight loss, or chest pain, or trouble swallowing, those kind of problems. By that time, usually the lung cancer has advanced.
So there's really a big focus on early detection.
That's right, and up till now, early detection really has been just the luck of the draw, folks getting a chest x-ray or a CAT scan for some other problem and finding an early lung cancer.
All right, and what are some of the common treatment options?
So for lung cancer, folks with the early stage lung cancer can have really a simple treatment. If they're well enough, they can have a surgery, typically have the tumor removed and not require any further therapy. Some folks who can't have the surgery can also have radiation treatments, and similarly, it's an effective treatment without a lot of side effects. But again, that's not the majority of patients. The majority of patients have advanced disease, and they require more toxic therapy, radiation, chemo, or a combination of radiation and chemotherapy.
And the patients that you see in your office, do you see it normally in the late stages?
That's right. So if you look at the stage diagnosis, more than half of patients are diagnosed with stage 4 metastatic disease. And most of the patients that we see and treat in our office have either advanced stage 3 disease or advanced stage 4 disease.
So would you say that's what makes lung cancer seem so deadly, is that it's found so late?
That's exactly it. Yeah, and so out of an incidence of probably 200,000 or 210,000 patients a year diagnosed with lung cancer, we have about 160,000 deaths. So that's a very poor treatment rate or cure rate for these patients.
All right, well, let's talk about some of the different stages of lung cancer.
Sure. Sure. So early localized stage 1 disease is really the tumor where this all started in the lung and it's not spread anywhere else. Stage 2 and 3 represent locally advanced disease with involvement of the lymph nodes, either very close to the tumor or in through the center of the chest. Stage 4 disease means that it's spread through the blood and either gone to another organ such as the liver or the brain or to the bones.
And you said you primarily are seeing stage 4?
Yeah, more than half of folks diagnosed with lung cancer are diagnosed with stage 4 disease every year in our country.
Wow, and what are the typical survival rates for the different stages? I know you provided us with a slide.
Right, right. So most of the data that I've brought is from the American Cancer Society or similar data groups that are pretty generally accepted as what's there. And for early stage 1 disease, it's still not a home run, but a 5-year overall survival rate is about 60%. That diminishes to about a 20% 5-year overall survival rate for stage 3 and much lower for stage 4. Usually that's 5% at best.
Wow, and something I read was that lung cancer deaths per year is equal to the deaths from 4 major other cancers combined.
Yeah.
Why do you think that is?
Well, that is largely because we have excellent screening for 3 of those cancers. We're talking about breast cancer, prostate cancer, and colorectal cancer. And over the last 30 years, we've implemented screening for all those and dramatically cut the death rate from those 3 types of cancers by at least 30% for each one of those. So those combined with pancreas cancer are the 4 major killers of folks cancer-wise outside of lung cancer. But as you mentioned, lung cancer takes more lives per year than all 4 of those combined, something around 160,000 American lives per year.
Well, we're going to talk a lot more in depth about screening, but just give us sort of an overview on the kind of screening you can do for lung cancer.
So the Medicare folks have approved payment for low-dose CT screening, and basically our goal there is to completely flip the stages of diagnosis. So instead of 60% of our patients having stage 4 disease, we want to find them with 60% or more having stage 1 disease.
Okay, and what do you think is important for people to know just about lung cancer in general before we start talking about the screening?
In lung cancer in general, we're at the threshold of a new era where we have the ability to find lung cancer at a curable, treatable stage, but it's going to rely on the adoption of this new screening guideline by the physicians and the community at large.
All right, Dr. Baisden, we're going to take a short break, but when we come back, we'll be talking about lung cancer survival rates here in West Virginia compared to that of the U.S. Don't go away. Good morning and welcome back to In Focus. I'm Courtney Clark. If you're just tuning in this morning, today we're talking about lung cancer, and I'm pleased to be joined by Dr. Baisden with 21st Century Oncology. It's great to have you here this morning.
Thank you.
So we've talked a lot about lung cancer in general, but we want to talk about some of the key statistics regarding lung cancer, both women and men.
Yeah. So as I mentioned earlier, men have had some decreased incidence in lung cancer, about 30% decrease over the last 20 to 30 years, but they still have a significantly higher rate of lung cancer compared to women. Essentially a 40% increase over women in the incidence, and that simply is corresponds to the rate of tobacco use. The rate of smoking is much greater for men than for women. There is some difference too regarding survival. So men, for whatever reason, don't do as well as women in surviving the disease with more advanced stage. We're not sure why, but that seems to be true.
And that's not because women are finding it earlier, that those statistics are after it's diagnosed?
Right. It doesn't seem to have any real impact regarding the survival per stage, where women finding it earlier. It just seems that women are doing better. Maybe they're tougher.
Yeah. Well, how do death rates in southern West Virginia compare with that of the rest of the U.S.?
Well, we live in the tobacco belt, so the death rates in West Virginia, southern West Virginia, are higher than the national average by about 25%. That goes hand in hand with the incidence rate. So we're really not any different in finding it at different stages. We find early lung cancer as well as anywhere else in the United States. But because we have a higher incidence and higher tobacco use, we have a higher death rate compared to the average, unfortunately.
And going back to the other risk factors, there's also being in the coal mines. They say, you know, that can affect it. Do you think that that's one of the reasons we're higher?
Absolutely. You know, it's not a simple fact of tobacco use, and the risk factors combine together to compound the problem. So folks that have multiple risks, such as tobacco use, occupational exposure, family history, have a much greater risk than folks with just one of those factors.
And what about compared to, like, let's say the Northeast and the Southeast? I mean, how do we compare to the rest of the country? I know we're...
Well, just in general, the Southeast is worse. This is the tobacco belt, you know, starting in Pennsylvania down. And the worst state in the United States for incidence and death rate is Kentucky. The best is Utah. those go completely hand in hand with tobacco use. So, you know, it's pretty cause and effect kind of thing. The Northeast, the West Coast seem to do better. There are pockets in the center of the country, in the north central regions, that also have low tobacco use, that have much better, lower rates of lung cancer incidence and death rate.
And how do you see us doing here in Mercer County as far as tobacco use goes?
It's very high rate of tobacco use, unfortunately. And, you know, we're seeing recent publications, too, regarding younger folks smoking more, and there's kind of an uptrend in folks using tobacco. In addition, now this new trend of the e-cigarettes, no one knows the long-term implications for lung cancer. Those have not been used and studied to know whether they have less of an effect on lung cancer than, say, traditional smoking tobacco or not. But we know that it's probably not a positive effect.
And we're talking about younger people using tobacco, but it seems that lung cancer is predominantly a disease of the elderly. Is that just because it takes some time to develop?
That's
obviously?
exactly right. That's exactly right. A lot of cancers are more prevalent with age, breast, colon, prostate cancers, and we know that that is an accumulation of a lifetime of genetic changes in these organs that are constantly growing and replacing themselves and healing themselves. And when we add that in there, the other insults, risk factors of tobacco use, occupational exposures, that means that folks at an older age are the highest risk and have the highest incidence. So over age 70 really is the highest incidence rate for all of these type of cancers, including lung cancer.
And we've talked about men and women. Are there racial differences as well?
There are very clear racial differences, and like the differences between men and women, we don't understand exactly why there are, but among the United States inhabitants, black folks have about, black men in particular, have about a 30 to 35% increased incidence in lung cancer compared to white men, but they don't use tobacco as much. So it's obviously some other factor. We don't know if that's a genetic factor or if that's some other risk factor. Interestingly, among women, black women have about the same rate of lung cancer as white women, despite less tobacco use than white women. Conversely, other minorities, Hispanic and Pacific Islanders and Native Americans, have a lower incidence of lung cancer for both men and women than either black or white Americans. So we don't know all the reasons for that, but there are clear, well-studied differences among the races.
Sure. Are there any other statistics that stand out to you that you think people should know about?
Well, clearly, you know, the biggest statistic and the important one for folks to know is finding this cancer early equals a better cure rate, to the tune of 60% cure rate at stage 1 versus finding it at a late stage. Those are really the take-home points regarding all of the data about lung cancer and its incidence.
Yeah, my next question was going to be, how can we change the statistics? But it sounds like early detection is the way to change
early detection. It's exactly like the other home runs we've hit in cancer care. They've not been so much techniques in treatment or developments of new chemotherapy. It's all been in finding cancers earlier. If you look at the parallel of breast cancer, if you look at prostate cancer, colorectal cancer, we have tens of thousands, if not close to 100,000 folks a year whose lives are saved because they have it found at a curable stage. And in addition, when it's found at a curable stage, for example, like women with early breast cancer, their 10-year cure rate for women with a mammogram-detected breast cancer is probably 98 or 99% according to the American Cancer Society, whereas if women don't get their screening and they find it themselves, it's probably half that or close to half that. So we think that lung cancer and being able to find it will be a similar home run to the other screening programs that have been implemented and save lives to the similar extent.
And 60%, you said at stage 1. I mean, that doesn't seem like it's that deadly, but how often do you find someone who is in stage 1?
Frequently, actually. I see a fair number of patients per year that I treat with radiation for stage 1 disease. Currently, surgery is the preferred method of treating these folks, but radiation is used for folks that can't have surgery because of lung problems, COPD, and there are a fair number of those. So I would say, I treat somewhere close to 12 to 15 patients in my clinic just from our community along those lines per year.
Wow, and going back to the symptoms, we just want people to be aware. I know you say there aren't symptoms a lot of the time, but if they are experiencing some of them, what would they be?
Absolutely. The symptoms from, a lung cancer, again, could be coughing up blood, could have trouble swallowing and weight loss, could also have chest pain, and the biggest one may be shortness of breath as well. So all of those things can happen.
And is there any particular group of people that should be more cautious than others? Say you think you've had an occupational experience or something like that.
Right. Yeah, the risk factors are clear, and those are the folks that need to be on close guard. So tobacco use, occupational exposures to fumes, occupational exposures in the coal mines, those kind of things. Family history, so there is some genetics behind lung cancer that we don't understand yet, but that's clearly a risk factor, so folks with family history need to have a closer eye for that as well. Secondhand exposure to smoke and a personal history of another type of cancer puts you at more risk for lung cancer as well.
And where should someone start if they think they'd like to be screened?
Well, it has to be ordered, so you have to see a physician. Typically, that would be a primary care physician if you don't have another specialist, or a pulmonologist would be if someone is already seeing a pulmonologist because they have a history of COPD or other problems. Those are the folks that can order these easily. But that's really probably the place to start. A lot of folks in our community don't seem to keep touch with primary care doctors, and so we're going to reach out and try and educate other providers, such as the emergency care providers. Maybe they can start screening folks that just come in through the emergency room department if they don't have a regular primary care physician as well.
All right, we're going to take another break, but when we come back, we'll talk more about the CT screening, the low-dose CT screening.
Right.
So don't go away. We'll be right back. Welcome back to In Focus. Thanks so much for joining us this morning. I'm Courtney Clark. Today our focus is on lung cancer, and I'm pleased to be joined by Dr. Joseph Baisden with 21st Century Oncology. Thanks for being here.
Thank you.
Well, we've talked a lot about sort of dark statistics regarding lung cancer, but let's talk about some positives, starting with the importance of this new low-dose CT screening.
Right. So I'm hoping that we can completely reverse these statistics and in a few years be talking about what a successful program this is with low-dose CT screening. It's something that we've been studying for more than a decade in our country as well as in other countries. And what has been recently proposed and adopted is the use of this yearly for folks at risk. What this will mean should be a significant reduction in the lung cancer mortality every year, and hopefully along the lines of 30 to 50,000 lives saved because of detecting these lung cancers in stage 1 rather than more advanced stage.
Wow, so why now?
Well, the reason now is that Medicare has spent some time reviewing the evidence behind this recommendation, and as we know in this age, it's a lot harder to get new treatments, new therapies paid for. We have to have more evidence, and the evidence behind this screening is very compelling. In fact, it's more powerful than a lot of the other screening that we've been using for many decades. So this all started with a trial called the National Lung Cancer Screening Trial, their NLST lung screening trial, and they took thousands of folks at risk for lung cancer, and one group they did a yearly chest x-ray, and the other group they did a yearly low-dose CAT scan. And what they found was that in the folks with the CAT scan, they had a 20% improvement in lung cancer mortality. So 20% less folks died from lung cancer after this 3-year period of screening compared to the chest x-ray use alone. That was so powerful it was a 6% improvement overall in survival from all causes for these folks. And, you know, we just don't see those kind of improvements in survival with any cancer studies nowadays. So this is truly a home run that compelled Medicare to start paying for this for everyone at risk.
Sounds like it. And how exactly does that screening work?
So the low-dose CT screening is different than a regular CAT scan. A lot of folks have had a CAT scan where they go in and get an IV. The low-dose CT, there's no IV involved. It's a very quick breath hold scan that takes about 15 seconds, and the radiation exposure is greatly reduced. So it's about a quarter of the exposure of a regular CT scan. And that's comparable to maybe 10 chest x-rays. So that is a very safe dose for folks to get yearly, long-term. And what it does is gives the radiologists a view of the lung that allows us to detect any lesions that would be big enough to be worried about. Those that are found aren't necessarily biopsied right away, but folks that have an abnormal scan will often have follow-up CT scans before any invasive procedure would be decided to be undertaken.
And about what age should that start for someone who's at risk?
We have very clear guidelines. Age 55 is where Medicare will start paying for this for folks at risk. The other factors are a significant history of smoking, 30-pack years, and having quit smoking in less than the last 15 years or still smoking. So that's the major guideline. For folks with a risk factor, that age is reduced to 50. So the risk factors we've mentioned earlier, occupational exposure, family history of lung cancer, personal history of another lung cancer, or a personal history of COPD, emphysema, along with a history of smoking.
And we talked about the death rates for lung cancer. And is this something that you see becoming as common as, let's say, mammograms with breast cancer?
I think that that's the way it should be approached. I think everyone, including the physicians ordering the yearly screening for mammography for women and the PSA checks for men, should hand in hand have the order for a low-dose CT screen for those folks at risk.
So is your goal really with the physician as well as the normal person watching who may have a risk factor for one of them to either approach your physician or for the physician to make that order?
Right. I implore folks, physicians and folks in the community to start adopting this because I truly believe there are lives to be saved everywhere in the United States. And here in our community, probably at least a dozen lives per year will be saved if we have full implementation of this low-dose CT screening.
And so this isn't something that you have to drive to Roanoke or Charleston to receive, correct?
Correct. I know there's at least one local community hospital that is ready and prepared to offer this the way that it's intended, with the lower dose, no IV, and with the quick scan. The rest of the imaging departments and hospitals, I'm sure, will be getting up to speed if they aren't already.
And going back to those statistics, talk about the potential impact that this could have on the men and women here in our area especially.
Right, so if we start finding more than half of our patients with stage 1 disease, you know, we're going to save probably 30,000 to 50,000 lives in the United States. And in our community, that probably represents 12 to 18 lives per year from lung cancer. And that's significant because we probably see somewhere around 60 to 80 lung cancer cases per year. So that's a huge portion of the lung cancer cases that we see every year.
And let's touch on those survival rates again. A huge difference between stage 1 and stage 4.
Yeah, the stage 1 is 60% at 5 years. Stage 4 is close to 0% at 5 years.
All right, so what else do you think is important for people to know about this that we haven't touched on this morning?
The other important things are finding this early allows for less toxic treatment. A lot of folks with a stage 1 disease can go and have a surgery and continue their functional lives afterwards, after some recuperation time, continue to work, continue to do things. The treatment doesn't have to be as toxic as what a lot of folks believe may be true. Additionally, these cancers are there. They're going to show themselves, and folks are going to either be found with an early disease because they've had low-dose CT, or they're going to have advanced disease and eventually have to go through that treatment either way.
And what's the difference between early stage treatment and late stage?
Right, so the early stage again would be a surgery, probably alone, or radiation alone, both focused to a small area of the body, versus late stage treatment. We're treating a much larger part of the chest with chemo and or radiation.
All right, so what would you say to someone who's watching who thinks, you know, I may be one of those people who needs to get checked out?
You need to make it happen. This is a transition that we're going through with folks adopting this. So ask your provider to get on board with this. Ask them to order this CT for you. It can be done locally, can be read locally, and it can be handled locally. We have very good guidelines of how to deal with it. And by doing it, and you find an early lung cancer, the life you could save could be your own. And for folks who have family members at risk, urge them, blackmail them, however you can get them to get this done.
And you say a lot of people don't even have a primary care physician, so that's a very good place to start.
That's a great place to start. You know, we have excellent group of primary care physicians in our community. They're accessible, they're willing to do what folks need for their care, and they're certainly going to be willing to adopt this.
All right, we have about 30 seconds left. I guess just tell us one more time the symptoms of lung cancer.
So a lot of times folks will present with shortness of breath, cough, weight loss, or even coughing up blood.
All right, Dr. Baisden with 21st Century Oncology, thanks so much. It's been a pleasure having you here this morning.
Thank you.
And thank you all for joining us. That does it for us on this edition of In Focus. We'll see you next time. Have a great day.